sure know that you're inside the follicle, not somewhere around it?
That's a very good question. In a 2D, you definitely can't be very sure, but once you are inside and you're put in the aspiration and the follicle size is diminishing and the tube is collecting with fluid, you're pretty sure that you're inside the follicle. Right, so this side is almost done. I'd like to welcome Dr. Sanjeev Sharma from the UK, and he's come all the way to be with us. He's also a very good teacher of the Royal College. And Dr. Sharma, if you don't mind, I'd like you to moderate the session as well, and would like to have your comments of this process. So the mic can be handed over to Dr. Sharma, please. Right, now this is the other ovary, and as you can see, there is a significant difference of response of the left and the right. And this is how many women respond, and this is how their ovarian reserve is variant from person to person. Again, I'm going into this needle, the needle into the follicle and aspirating. Sometimes we may not get in. Sorry, can I have the picture back? If you can see the fluid, sometimes if you can follow the fluid, please. The fluid is a clear fluid is always best, and we must try to avoid as much as blood in the follicle fluid that we collected. I always, can I have the size reduced, please? So once I finish the pickup, I always have a look at the endometrium.
Have you given her an estradiol valerate supplementation? Because the endometrium looks very thick to me, Kaberi.
Not really. I agree with you. It's a thick endometrium, and also I can see a little bit of fluid inside.
Fluid in that.
Yeah, so
that must be giving you a little jitters, I'm sure.
Absolutely, very much. So I'll really think twice before I decide to do transfer in this patient.
Cycle,
yeah,
probably, yeah, absolutely.
Dr. Kaberi, do you go for aspirating the fluid? Have you done that?
Done it once or twice, not given good results, so I avoid it. So if there is fluid, then I would freeze all embryos and go for.
What could explain the presence of this fluid? Any idea on why it happens and why does it appear?
Most fluids are because of hydrosalpinges, but she's had a laparoscopy earlier and she has no documented hydrosalpinge. Sometimes when there is hyperstimulation, the fluid from the peritoneal cavity might get sucked through the tubes and it may be visible inside the endometrial cavity. So about 60% of endometrial fluid on day of pickup is, if you can say, use the word idiopathic, and 40% will be because of some reason, pelvic infection or hydrosalpinges. There have been various studies to say whether you should transfer or not transfer. Many people say that if you do a scan again, if there's very minimal fluid like this one, and if
you can go ahead.
Yeah.
And you should do it on the day of the embryo transfer.
Exactly.
Review again on the day of embryo transfer.
Exactly. Now, before I wind up, I just wanted to quickly demonstrate you just the process of transabdominal on this very patient. If you can focus on the abdomen, and obviously you need to clean drape this area with betadine, and then wash with a lot of normal saline to be sure. And then we are usually the transabdominal collection is done when it is done for cases of Mayer-Rokitansky syndrome, where it's difficult to put in the vaginal probe, where there is excessive pelvic infection, where the ovaries are high up, it's not accessible transvaginally. And then you would want to put your probe this way and be able to see the transabdominal ovary on your screen. You can put a little bit of local if you want. No, I just want it here because she does not have transabdominal, it's just for demonstration. Can I have the camera just on the probe, please?
No, actually the transabdominal probe is not available right now, I suppose.
Yeah, and also because of the needle guide, which is not easily available with transabdominal.
Okay, you are aspirating the follicle.
Yeah, I'm just demonstrating how this setup is going to be.
Yeah.
So you would
just demonstrating it.
Yeah. So you would just put in your needle the way it is, and we have done a few transabdominal collections and we've got oocytes. I would agree slightly less than how much we would get by transvaginal. So you just go in like this and then you breach through the skin and you go into your ovaries. The ovaries are high up, remember, and they're almost close to the abdominal wall. You have to be very sure that they are high up. So if they are deep down, it's best not to go the transabdominal route. There's a lot of risk of bowel injury, etc. They need to be visible very close to the subcutaneous abdomen. And this is just a demonstration of how TVS, transabdominal egg collection, can be tried. I would definitely not recommend it on people who are new to oocyte retrieval. And this is for those special cases where TVS oocyte recovery is absolutely impossible. So I'll wind up now here from the OT and would ask Vandana or Parul to carry on with the next session. Thank you very much.
Dr. Kaberi, there is one question from the audience.
Sure.
Yeah, I just wanted to know if we use the same probe transvaginal with the blood.
Can you hear?
Can I have the camera on me?
Okay, on it. See, there is a question that are you using the same probe?
Yes, there have been various, even the transabdominal has a needle guide to go through, and you can use, technically you can use a transabdominal probe with a needle guide to go, but the oocyte aspiration needle is designed mainly for transvaginal oocyte collection, and it fits in well with the transvaginal needle with the probe guide. So it's easier to do oocyte collection even transabdominally with the same setup.
Thank you.
Okay, thank you very much.
Hello, Kaberi. You are using rubber gloves. Is it okay?
Sorry?
The gloves? No, they are non-powdered.
Okay. Yeah,
these brown ones are the non-powdered gloves.
Okay.
Yes.
In the place of it, you can use also the paper gloves also.
Okay.
But sterile
ones. Powdered, you can use.
But it should be sterile one. Should come in a sterile pack.
Okay. Thank you.
Right.
Hello, Kaberi.
Yes, ma'am. Good afternoon. Welcome, ma'am. Yes,
I have seen your excellent ovum picker.
Thank you so much,
Very
ma'am.
beautifully you did.
Thank you, ma'am.
I'm sitting here since 11:30, seen the both cases beautifully.
Yeah, thank you so much, ma'am. Thank you for coming.
I congratulate you for the good CME.
Thank you so much, ma'am. Thank you. Thank you.
Okay, then bye-bye.
So we'd like to continue with the next session and want the camera and sound off from the OT, please. Move on. Parul, I'll take over because we're running short of time. So we're going to move straight over to first demonstration of our embryo transfer.
Sure.
And while our next patient is getting ready, I'll have a 5-minute presentation on the tips and tricks, if there are any. As we have seen, evidence is lacking, but lack of evidence may not mean lack of effect. So let's keep that in mind, and I'm going to proceed today. Both the cases are mock, and we've had a day 3 and we have a blast transfer tomorrow, so we're not taking live cases, but we'll run through it exactly as we would do in a live case. And our protocol here is fresh transfer on day 3 if we have less than 6 to 7 grade A embryos. But if we have more, then we may keep them for a day 5 blastocyst transfer. So the presentation right now is going to be straight on the procedure of embryo transfer. And I'm going to start off by demonstrating to you the catheter. We're using the Cook catheter, and as you see, there is an outer